HIPcast is brought to you by Enterprise Social Record.
Today, we have a very unique guest with us. A lot of times when we talk about our health information journey on this show and our professionals tell us how they found our profession, usually they've just accidentally stumbled upon it. And that was, something that they did. Most of us, it's our early career, or first career. Well, today, Dr. Jeff Weiner joins us, and he is a very accomplished physician, clinician, and has a great backstory. I cannot wait for him to tell you his introduction. However, what I love about today's guest is that he decided as a clinician that health informatics was important enough to go back and learn informaticist. So we have Dr. Jeff Weiner with us today. Welcome to the show, sir. Yeah, we're excited.
We had a mutual friend, Laretha, connect us up, and Laretha's my cohort. She helps. We both work on THIMA, the Health Information Management Association, together, and try to keep that thing on the rails. And it's always fun. We have a unique text group where we send each other all kinds of craziness. So appreciate Laretha connecting us up. And one of the questions we always ask is, what's your story? So tell us about your career journey. How did you end up, like Shannan said, finding the MHIM program, which is always fun to say. And but that's just the one peg in the book there of everything that you've accomplished.
It is a long story, so I'll try to give the short version of it, but I will go all the way back to, I was a nerd first and foremost, math, science, etc. Wasn't really sure what I was going to do with that when I was in high school, but then my sister Allie was diagnosed with type 1 diabetes. And at that time, we actually had a science research program in my high school, and was introduced to this concept of biostatistics and research and all these things. And went to college thinking I was going to do an MD PhD, and be the one who was going to cure diabetes one day. Got to work at a diabetes camp and realized that, actually I really, really liked the clinical part, and dropped the PhD for my application. So went to med school knowing I was going to do pediatrics. Eventually went into pediatric hospital medicine and did a 3-year fellowship at Children's National in Washington, D.C. And there I was introduced not only to the research stuff, but also to quality improvement, medical education, and really kind of made an early career out of mentoring early faculty and trainees through their first project across those various fields. After a year on faculty in Washington, D.C., went to Jacksonville, was there for 4 years in Florida, doing a lot of the same stuff. But there I started to work that much more with the EHR, and realizing that quality improvement in particular could have long-term sustainable ramifications, especially if we could hard code something or find ways to, help people, make the right thing easy, make the wrong thing hard. So after 4 years there, I came to Memphis to work at Bonner Children's Hospital, and got access back to a multi-hospital big data database called PHIS, a Pediatric Health Information System. And through that, really got connected with the data people at the hospital. At that time, they were working a lot on getting together and having data governance around, especially requests, research, quality, operations would all get similar requests, and were working in their own silos before that. And so when our hospital system was switching EHRs from Cerner to Epic, I kind of became identified as the pediatric initially representative for that. And then eventually, in the absence of having a physician leader for the system, actually was the physician champion there. We went live in October of 2024, and in November of that year, I became the Chief Medical Informatics Officer here. Now, that gets into that MHIIM part of it, right? I will say there is clinical boards for clinical informatics. Right up through last year in June, you could apply for that through either doing a 2-year fellowship or qualifying by a practice pathway. The practice pathway was one of two things. You could either have been in a formal informatics role at least a quarter of your time for at least 3 consecutive years leading up to that, or you could complete a 24-month master's. And I got my position 27 months before the cutoff. Not quite long enough, but just long enough, that I started looking for, are there master's programs out there? And to be completely honest, it started as a check mark, right? It was, I want this endpoint, and the only way I'm going to do that other than, quitting my job and being a fellow for 2 years is getting a master's. I was lucky that there was one at University of Tennessee Health Science Center, which I was faculty for, and even better than getting a local master's, getting a local free master's.
Yeah,
right, subsidized. But what wound up happening, which was so cool, was that there started to be these serendipitous just synchronies of, I was taking a class, we were learning about the legal aspects and the various laws over time, and all of a sudden the next week after I wrote that paper, I'm in a meeting and we're discussing information sharing and how to avoid the problems from 21st Century Cures Act. And and every single class I was taking, there was something like that where it was like, oh, I can be the one to speak to this because I just learned this. And then in October of last year, when I sat for those boards, man, were there a lot of questions I learned in the program, I will say. But it was really cool, in addition, to see all of those various other backgrounds and professions that are there. There was a large pharmacy contingent, for example. There's a dual program. And then also out of the woodworks, Loretta included Loretta Hinton, Sherry Henderson, just to name a few. But I started being like, finding these people who I knew who were in various parts of the system who were graduates of the same program. So I'll stop there because I've gone for a while, but that's kind of most of it, I think.
How serendipitous, though, for sure, of how you were able to immediately apply in real time. That says a lot about the curriculum at the program at the UT Health Science Center, that they are that up to date, that it's applicable immediately. That's
Absolutely.
Pretty awesome.
Without question.
Yeah, that's a lot of fun. And one of the things that I really enjoyed when I was going through my different degree paths was that cohort of people, because it is people from all different backgrounds and all different walks of healthcare, some not even in healthcare. There was a guy that was in my DHA program that was an author. He had written a bunch of books and wanted to get a doctorate, and that's the pathway that he took, was health administration. So his perspectives of healthcare, when we would do our message boards and group work and whatnot, we're all part of the system per se, and his perspective was the patient. He's like, I've never worked in this before, and it was really fascinating to have that perspective in those discussion boards and hear it from his side. So it's pretty fascinating. Something that we always talk about, because we have a lot of students, a lot of programs across the country that have their students listen to HIPcast, is we always encourage folks, as when it's time to continue your education, keep building and going and going and going. I find it a little bit fascinating because you went to some fairly prestigious programs,
fairly prestigious,
some Ivy League programs to go through and get the MD, but then you went back to a master's degree, which is fascinating to me because it's just it's another tool in the tool belt, right? And that's the fun thing. And so I think that's a good encouragement to folks that are young professionals or students or even folks that have been in the industry for 20, 30 years, that you don't have to keep progressing towards a certain level. You can go get a different degree in a different area and gain that education that would apply to your career path.
Oh, absolutely. And it does two things. First of all, it rounds out, and I think that tool belt metaphor is the one that I use most often, because with my background, I have all of those various things. Now, they all are coming in to this role right now, and it feels like the number of times where I'm like, oh, that's why I went through that thing 10 years ago. That's why, I got this extra part. It was all to prepare for right now. But also it's not where I expected to be at the beginning, but looking back, it is such a good fit for me, for my personality, that skills, need, passion, kind of finding its place together in information.
Yeah, it's definitely a need in the marketplace, especially as data is just exploding and continues to explode, and AI is going to solve everything, and we're never going to have to do everything, anything again. So
you must have been watching Davos this week, and you're buying in.
Yeah, exactly. So what does it mean to be a board certified clinical informaticist? That's quite the title there, and I think you've touched on a little bit of the pathways, but expand on that.
Yeah. So there obviously for a long time have been physicians who are also working in informatics or information management. The American Board of Preventive Medicine actually created a board. I'm going to get the years wrong if I try to guess, but a while ago, to recognize and certify those people who have both the experience and the expertise in it. As with most of these things, early on, a lot of people are able to grandfather in because they've already been doing so. And actually, it was set to close out in 2022. But there was an extension to the 2025, which I took advantage of. But the idea is that for physicians who have another primary board certification, so with mine is American Board of Pediatrics, but it could be anything, to get a secondary in this, really, like I said, more than anything, with a lot of things, and this goes back to that mentorship around scholarship and other things, right? Promotion, titles, all of these things in a perfect world become the natural outcome of doing the right things. And so again, with the story, if it weren't for this board existing, if it weren't for wanting to have that label, I wouldn't have done the program, and I wouldn't have been as good as what I was doing the last 3 years.
I love that advice, though, that doing the right thing, the rest of it will fall into place. I think
it doesn't need to be for a degree. It doesn't need to be for exactly. I mean, nowadays there's so much available, whether it's LinkedIn Learning, whether it's Microsoft Learn. There's so many places to round that out and get the knowledge, so that when the time comes, you can raise your hand and step in.
Yeah, we need a motivational poster with you saying that, because that's good. My mind initially went to, there has to be a biblical proverb that follows that, but I couldn't think of one. My brain only went to the movie Frozen 2 because I have daughters, and it was take the right next step, I believe, is the thing in Frozen 2. So, I was hoping to come up with a biblical proverb there, but that totally failed.
There's a scientist, I'm blanking on who it is now. But the one that I always go to is chance favors the prepared.
Yeah.
Oh,
I love it. Really and good. That's informatics for sure, right? I mean, when you're projecting anything based on historical data, you're really predicting, and it is chance. Like, hey, if this happens, this is what it would impact in patient safety or in costs or whatever. I appreciate that you talked about the fact that the board certification is there, because that's important to providers. They're not just going to take arbitrary education, even if you're doing the work already. You said earlier, you're kind of a nerd. And so even if you were already looking at the data and nerding out on the data, it wasn't formal. It was just you learning and self-teaching, or, taking in data and consuming it and forming your thoughts on that. But having that board certification is motivating for providers so that they're dual certified. And so I think that's awesome. Now, from my side, right, from our health information journey side, being non-clinicians, I have a view of what the role of informatics is in kind of that bridge between clinical ops, IT, finance, and all of those different things. From a clinician side, I think you probably have a maybe we get to the same outcome, right? But I bet you have a little bit of a different take than the traditional health information informatics major. So from your perspective, what is that role of informatics between those different segments within a healthcare system, clinical operations, IT, finance, and what that is?
Yeah. I mean, if I use one word, it's interpreter, right? We're the liaison, we're the in-between. Within the EPIC, I have physician builder and advanced training similar to that of an analyst. I don't do the builds though, but I know the system well enough, just as a small example of this, to say, okay, this is the thing that this doctor is asking. Here's the best way to do it, or at least a really good way to do it in EPIC. Analyst, this is what it might look like to do it that way. And this is why it's going to work, or this is why what we have right now isn't working. And to be able to be that in between, to smooth things over, to knock down the wall that traditionally things got passed over back and forth of the, we asked for this, they spent however many months, they came back, it's not what we asked for. And if we can get that half the time and twice as good, then we've been successful in some way. Similar on the data, similar on HIM, legal, compliance. I mean, I work with every single one of those departments, information security, IT, I mean, operations. It's all there because everything is so integrated right now. And the one thing in going to EPIC and to a modern EHR is, I think we honestly made a little bit of a mistake. I talk about this a lot, of letting people think that it was going to be simple.
Yeah, that's a big, huge mistake.
This is, you're telling me I have to do it this exact way. It used to be so much simpler. And what I tell people is, it was really, really simple, was paper, right? You had a blank piece of paper, you could write whatever you wanted. Some human would try to interpret it, maybe get it right, maybe get it wrong. Early EMRs, and I can talk a little bit about why I use EMR and EHR separately, were really computerized paper charts in a lot of ways. A lot of the actions you would take, instead of sending the physical piece of paper, would print out somewhere or would show up on a person's list, and then they would act on it. But what we have now is really complex systems, and the goal of informatics is to find the simplicity, not on the near side, but on the far side of that complexity, right? If we can make it so that, like I said, the easy way puts the right data in the right place, that the system can interpret the right way and take action on in the background without you even realizing that it's doing it, then we've made it better. But if we leave it in a way that it's hard and people are just free texting things in instead of putting it in discrete, or there's 3 different ways to put something in and only one of them actually drives the actions, then that's where we wind up feeling the complexity and falling.
It's interesting. I want to say something, and I don't want it to, like, for the people listening, I don't want anybody to think I'm viewing this as a step backward. But I fear that the industry might view what I'm about to say as a step backward. But in my opinion, it's always been the case. Data, as we talked about just in discussion before we started recording, besides human capital, data is the most important asset we have. And it has to be accurate and appropriate and accessible and, all of the things that apply. But from a clinician standpoint, what you just went through and, kind of that perspective from that clinician side, I was thinking as you were talking in the early part of this, that you become in this role, you are almost like a new type of product owner where you're owning raw data and system integration to get the outcomes of that data so that you can make organizational decisions. And so making that like a raw data product owner, in a sense, the data steward, to some people, that might sound like it's taking you back or diminishing your capacity as an accomplished and very successful caring provider, but it isn't at all. It's actually expanding that because so talk a little bit about that, if you will, just to say just the value and the importance of that data. It's not being a data steward is not an easy task. First of all, it's not easy, and it is not for someone who is not skilled in such. So, yeah, just talk about that a little, if you could.
I mean, the information and the output that we get can only be as good as the information put in. And thinking about data governance from the entire span of things, from creation and entry to use to eventual destruction, is really, really important.
Yes.
I think about, for example, you get this garbage in, garbage out thing that we're trying to get rid of. And this is actually a good point to come back to that EMR versus EHR, because one of the things that we did in moving to Epic, I mentioned Cerner because I'm an inpatient doc, but a lot of our clinics were on eClinicalWorks or all scripts. We had 3 separate, and actually, if you count total systems, I think the count was somewhere in the 8 to 9 range.
Goodness.
United in a single health record across the continuum of care. And we have a lot of situations now where people are like, I don't understand why this is so messy now. I'm seeing all these medications, they've got 3 prescriptions for the same thing and all of this. And the analogy that I use is, and this one I think might be biblical, Seth. I know it from Never-Ending Story, but it's the question of, do you take the path of easy lies or the path of hard truths? Right. In an EMR setting where you are talking about your clinic round scope, you're taking that big giant room in the back with the color-coded charts and now putting it in a computer, but you only see your part. And it looks really simple.
Yeah.
But, if that patient is only listing to you the meds that they are taking, they might have been prescribed something that they're not taking, that they should be taking, that has a side effect. And would you rather just close your eyes to it, or would you rather see the messiness and be able to push through that? The goal, again, is that simplicity on the far end of it. So I'll use an example, one of the ones that I'm really proud of. We have this concept, especially in the Children's Hospital, but it's across the system as well, of maintaining who our watchers are, right? What are the patients that we're keeping a close eye, we think might be unstable, or that other people need to be aware of? And what used to happen, and to some extent still is that the nurse teams would keep track of which watchers they had. The docs would keep track of which watchers they had. It all got reported out as a hospital, at 9 o'clock in the morning. So the 8 o'clock hour was nurses calling hospital teams, residents calling the nurse leaders saying, hey, on my list, these are the ones I have listed as watcher. Is it the same? Do you have anyone else, or do you think one of these isn't? Going back to that concept of data governance, and there's lots of aspects of data governance, but
so many.
The data quality perspective, in my mind, the litmus test is if two people in the system are asking the same question, do they get the same answer? Right?
That's good.
And so we created, actually, instead of having on the physician handoff a text field to put if patient was stable, watcher, unstable, or getting ready to discharge, we created a discrete flow sheet row at a patient level.
That's awesome.
And patient list columns that live on both the physician and the nursing or anyone else who wants to add them lists. And so if I ask the question, is this patient a watcher? Now, the question of should the patient be a watcher might be different.
Right. Totally different.
Is this patient currently a watcher? There's a definitive answer to that.
That's
and
good.
Who are all of the watchers in the hospital? There's a list for that as well, right?
That's good.
And we now have the visibility to, oh, actually, this patient isn't on the list and I think they should be. Now let's escalate on that one patient and discuss, as opposed to having the conversation about maybe the 5 patients, 4 of which are no-brainers. And why are we even mentioning it when it exists somewhere else that we can find? My dream is to have those big safety huddles that people have.
Yeah.
To have people just show up to it and have a dashboard that we can scroll top to bottom and not have to gather data in advance.
Yeah.
But to your point, that not only is the analyst who creates that dashboard, but it's also only as good as the quality of the data coming to it. And if people are keeping things outside of the system on paper, or if there isn't a single source of truth for it, then we're never going to be able to get to that, hey, I've been taking care of patients right up to the point where this meeting starts, and now I can get on the meeting and not miss a thing.
Yeah, I promise you there are people that are still keeping that data on paper somewhere.
Yeah.
I had a vendor that worked once that I brought into an enterprise. And one of the things that they said is every company has at least one Bob, and Bob keeps his own Excel sheets. And that's the golden rule. And everybody has to go to Bob to get that information. So I appreciate that. There's in the prep for this, we talked about one of the questions to consider and talk about today was what role does health information professionals play today in healthcare? I want to add to that just a little and ask you a personal question at the end of that. So tell us what role health information professionals play in healthcare today. And then when you get past that, would you tell us, has your master's in health information, informatics and information, has that changed your view of health information professionals? Whether it was just giving you recognition of who they are or just having a better understanding of them. I'd love from the personal perspective of a clinician, what did that do to impact your relationship to health information professionals?
Absolutely. I think more than anything, I realize more the breadth now, right? Like there's HIM over there, but at the same time, when we're talking about clinical quality, when we're talking about compliance, when we're talking about all these aspects, having the knowledge, maybe not the title, but the knowledge that's needed for information management.
Yeah.
I don't know that anybody in a leadership position can do it without it in any area right now. And so I think that you used the word stewards before, but I think the stewards of that knowledge become that much more important. And so I think that's been the most important thing. The question of where does this answer live?
Yeah.
And is it trustworthy? Right. I'll give an example. This is going off subject of your question, but The other thing that we're working on right now is working on an enterprise data dictionary. What are the terms we use? What's the exact source of it? What's the exact meaning of it? Because early on, for example, I'll use length of stay as an example. People would look at the length of stay measure that's benchmarked, that's standard, that's in Epic, and say, this isn't the number that we're used to. This is apples to oranges. I'm going to write my own report. I'm going to figure it out from my definition, right? And not to get too much in the weeds, but length of stay in Epic is number of inpatient days for inpatients, which is really, really important from a rev cycle perspective, right?
Huge.
But if you're trying to get patients out of the ED and up to the floor, it doesn't matter if they're obs or inpatient. It just matters that they're there. And so for a while there was, are we using the Epic definition of length of stay, or are we using our definition of length of stay? And only a couple of months ago, and it is embarrassing to say that because we've been working on the project for almost 3 years now, and been live for over a year. But I was looking through top to bottom every benchmarked metric that Epic has to see which ones we wanted to use for a strategic plan. And there was one sitting there called total duration of encounter. It is a standard metric. It is defined. It is benchmarked against other organizations. And it is that other definition of length of stay that everybody's been using all along.
Oh my goodness.
Right? And so, that's just a small example. But then you talk about who gets what information and how it's shared. And especially as we're now, we haven't even touched on the patient side of this, the advanced portals. And I think one of the biggest changes is access to information. And with especially, and we can kind of talk a little bit about any part of AI as well, but I think with the recent announcements of a number of AI health platforms, right? It's interesting because the role of the clinician, the role of the information management professional, right? Actually now becomes even more of the interpreter and the presenter and the filter, because that patient that got those labs, in the old days, it might be 3 days later that a nurse or a physician gets to call them, hey, here's what they are, here's what it means. But nowadays, 2 hours later, they get a ping on their phone and they're looking at these and there's a bunch of red on it, right? I had a friend recently who said, I went to get labs and everything was normal except, I forget what it was, but my ALK phos was low. It was like, cool, we don't care about that. Like, I've never worried about a low ALK phos in my life, in my entire career, but it was red and it had a down arrow right next to it. And there's no reason that person shouldn't be worried about it without having not only medical, I won't even call it literacy, but expertise, which is not fair. And, how do we write our notes in an age where every single one is immediately readable by the patient? How do we communicate when we're walking into the room and the patient already knows the numbers we're about to read? Even I work on academic teams with interns, residents, fellows. There might be 8 people on the team, and we're still rounding the way that we did when I was a resident on paper. And I sometimes ask, I say, why are we reading all these numbers when every single person on the team, including the patient, has already seen them
That's a
I know
great
why I
call
did
out
it when
for
I was
efficiency,
president,
right?
right?
Operational efficiency
Exactly. The
impact.
reason I did it as a resident was because I was holding the one copy of it and no one else had seen it yet. I'm
Now everybody's seen it
It's
and they've
absolutely
received an
true.
AI summary on it.
Yeah.
with data, can we move from data to information and wisdom and those higher levels and talk more about what's important, what does it mean, than about a list of numbers, 8 out of 10 of which don't matter.
Yeah. Well, that's fantastic to think about the future of where things are going, because we've talked about the complexity of healthcare, the complexity of health information, and then you add in additional tools like this that are now going to be also generating information, whether it's a summary or whatnot. And it kind of is a little bit scary for me to think about of where all this is going. But what do you see the future of health information, especially in an AI driven health system? And there's a health system that was purchased by a PE firm in Ohio that they're going full AI forward on everything. So the whole marketplace is about to be completely upended, in my opinion, of how we operationalize healthcare, but how we operationalize the technology in healthcare.
Mm-hmm.
But we also have to remember it's still my mother sitting there in that bed. It's still my child sitting there in that bed. There has to be a human approach to this.
Absolutely. We have another hour to talk about my feelings on AI. No, I'll try to be brief. First of all, I think governance is the single most important aspect. I think you need to know what you're bringing in, how you're using it, where your information is going now, right? There's this weird paradox where everybody wants the best trained models and nobody wants their patients in them. I think AI, especially getting integrated into health records, is going to be incredibly powerful. Epic now has a generative AI tool. I mean, they have probably about, I think, almost 100 at this point. But one that I'm really, really fascinated with is the ambulatory inpatient and especially the ED summary, right? A patient comes in extremis, they're a patient maybe from elsewhere, because interoperability, we have access to their records elsewhere. And that ED doc presses a single button and gets a 3-paragraph summary of their problems, what's going on, what they might need to know, rather than having to search through this chart for it. Which they're not going to do. They don't have time. There's a recent study that showed 30% of the time critical data was found by the AI that would have been missed otherwise.
Wow.
The other
30% of the time. That's
really
huge.
Excited. We actually recently started a pilot in our ambulatory clinics of ambient listening AI, right? And so the idea is, as opposed to having what some people used to use, a human scribe, or having to jot down the notes or be looking at your computer the whole time you're with a patient, you walk in, you always ask permission. You say, hey, if it's okay, I'm going to record the conversation. This is going to help me remember everything that I need to, and it will help me write the note to be as complete as possible. And more than 95% of patients are very happy with it, across all demographics. It's really kind of interesting. And obviously there's efficiency gains and I think accuracy gains, that data going into the system. One of the challenges with it is, do we lose our discrete data? Because right now it's creating the smartest dumb node or the dumbest node that you have. In the future, it will be able to say, oh, you said wheezing, the wheezing field is a yes. But right now it's, you said wheezing, the note has WHEEZING in it. But the thing that I'm most excited about with the ambient, and we've already seen, is not just the efficiency, not just the physician well-being from a time perspective, but the humanism. The idea,
I love it.
and I, nowadays with meetings, many people are having AI recording. And the experience that I've seen, whether it's the ambient in the room, whether it's on a meeting, is the eye contact, the human connection, the conversation, the presence that people can have, the mindfulness when they know that they don't have to remember this, that it is, they trust that it's there somewhere and aren't carrying that extra cognitive burden, aren't, you know, thinking about what they're writing while they're missing the next important point. Mm-hmm. I think that may be the thing that brings joy back to the medical profession. Wow. Getting That's the people awesome. Who wanted to help other humans through their health problems have as much time in the day to do that as possible.
Yeah, that's awesome.
Yeah, it's very exciting. And the AI tools, I was thinking about a meeting that I had this week where we couldn't get into a conference room, so we just did a stand-up meeting in the hallway, and I thought, I'm going to miss the AI summary of this meeting because we're not recording, and I'm trying to remember write down my notes.
Yeah.
So like I said, we're doing the pilot in ambulatory, and I'm a hospitalist, right? And typically when I'm on service, especially in this role, I'm on with the residents because it allows, I'm still taking care of the patients, but if there's an important meeting, if there's something, I can schedule the day around. But over New Year's, I was on what we call our attending only service. So it was just me and the patients, every order, every note, every nurse call, every consultant right here.
That's awesome.
And I didn't realize I was missing it until I was doing that.
Yeah, that's a lot of information to consume.
I was suddenly so aware of having that conversation for 45 minutes with the complex patient's parent and coming out. And my first thought is, oh my gosh, I need to write as much of it down as I can immediately. I don't know that I even realized it until I knew there was an alternative.
Yeah.
Well, I think you're right. It's going to bring joy back especially to the provider side of the world, because I know of providers that they spend all day long seeing patients, and then they come home at night and on the weekends, and they're trying to catch up on notes. And there's no way 3 days later, when they're sitting there on Saturday morning trying to catch up on all their documentation, that they remember all of those little minute details, especially in a complex patient. So having the tools and the technology and not being afraid of it, to be able to help them have joy back into patient care is going to improve the patient experience. It's going to improve the provider experience. It's going to be a great improvement for all. It's a rising tide raises all boats, right? And that's kind of where we're heading.
If it's okay, I'm going to read one of the emails that I got from one of the physicians in our system. I have my thoughts on deck. It is life-changing for me, not to be dramatic. First, the obvious, I spend less time at home charting, tremendous help with ever difficult work-life balance problem. Secondly, I don't forget information from visits. Case in point, I ended up sick with the flu last week and had to finish notes from before when I got well again. The information was already in the notes, only needed to review. Luckily, I wasn't trying to remember back to get the details. Lastly, the one I did not anticipate, the change in my patient experience. Now I get to go in the room, get everything started, and just sit and talk with patients with eye contact. I rarely use my computer unless referring to something in their chart. It made for a better experience. Sorry, I'm going to get emotional. For me, the provider, to engage better with patients while also knowing that everything I need was still captured in the note. It's also incredibly easy to use. Training was helpful. My one-on-one was great, and I was able to hit the ground running.
That's powerful.
That's one of many. That happens to be my favorite, but
so you keep it handy.
Yeah, exactly.
You keep it handy to remind you of on those really tough days.
Exactly, and it gets back to that. Why would someone who spent all those years getting the MD, going through residency, going through a clinical fellowship, take time back? I do 5 weeks a year of service. Now everything else I do is in informatics. But that's why.
It's fantastic. Well, this has
that's
been
awesome.
a fantastic conversation, Dr. Weiner. Thank you for joining us and encouraging our audience and sharing your experience with our audience. And now that I know that you're a graduate of UTHSC, that you are now brought into the THIMA family, you
That's
have
right.
to come hang out with us at our party in March
That's
at our
right.
annual meeting. So we're excited for it. Thank you for being here. It's been a pleasure.
Yes. Before I forget, just do want to shout out that program again, and particularly Dr. Reynolds, Dr. Sharp, who
she's amazing.
I think health information as a profession in Memphis is infinitely better for having that program there and for having the leadership.
Absolutely. And we're celebrating the 50th anniversary of that program, the UTHSC program, at our annual meeting in March. So that'll be an exciting party. So thank you again for being here, Shannan. Until next time, my friend.
I'll see you next time, buddy.